Hey, everybody. Welcome back to the Prehospital Paradigm Podcast. I'm Scott Wildenheim. The whole team is here again. It's been a while, guys. We got Caleb Froney off to my left, Ray Pace to my right. Other side of the table there, we got Dr. John Hill. Guys, we got, I don't know if you guys have seen any of this. John and I have seen a few of these. But we got another grab bag episode of just all kinds of randomness and stuff that... A couple of these things are questions that have been posed to us directly, and a couple of these are questions that have been peppered into our form in our website.
There's a way people can go online and ask us questions?
There is a way,
Huh.
yes.
And there are actually people asking us
and
questions.
And there are actually we got quite a few here, and some, or obviously we don't We're going to try to answer them as best we can. I'll leave it at that. Some of these are, I think there's probably a story behind the question, but
sure.
We'll try to tease out as much as we can.
I'm going to level it too. I have not seen any of these.
Yeah, you guys haven't seen.
I've not seen any of them.
All right, let's hop right into this, and this first one this is pretty good. The how do I differentiate cardiac chest pain from non-cardiac causes?
Assessment.
That's okay. Number 2, so
no, that's a good question.
That is a good question, and I think that the old adage of, well, if you can palpate it, it's not cardiac. We know that's
reassuring.
It's reassuring,
but honestly, from a pre-hospital standpoint, you can't totally exclude cardiac chest pain pre-hospital. Even in the ED, I can't exclude cardiac chest pain. It's a gestalt, it's using tools, it's using troponins, it's EKGs, it's chest x-rays, it's physical exam
whole
findings.
picture, yeah.
It's a whole picture. And still at that point, we're risk stratifying people, low risk, medium risk, high risk, right? But, I mean, and we even say things, because we know that when we go on individuals that are just recently under arrest, and we call it incarceritis, and they're complaining of chest pain, we have that thought in the back of our head, like, are they trying to just get out of being arrested? However, if they have chest pain, I'll make this as one of these things. You just can't ignore it. Treat it as real chest pain. We can't prove that it's not something cardiac that's going on. We have a bunch of stories, and it happened to us in residency, where we had someone that had a clean stress test the day before, and the next day they're having an MI.
Yeah.
We have these tools that stratify people, and that's all it is. They can still have major events. You can have plaques that rupture, and then all of a sudden you're having an MI. Yeah. So maybe that plaque ruptures when you're running from the police, and now you're having a cardiac event. So the short answer is you can't, but there's still tools we can talk about the process of giving that history, doing that physical exam, and then risk stratifying those individuals.
Yeah, and I can't remember how long ago I read this, but there was some percentage of actual legitimate had a vessel occlusion that had palpatable reproducible chest pain with that. So just piling on to it can't ever be completely excluded.
I think the more important point is that pain from here to here should be considered chest pain and cardiac nature until we prove it otherwise.
Cardiac or vascular.
Yeah. It should be up to us to hopefully guide ourselves away from cardiac vascular and say, okay, this is more probably, costochondritis or something else along those lines. Yeah. And then I'm feeling better, and I'll get you to the ER for definitive care of, like you said, you're going to need more laboratory workups, troponins, and imaging just to get a better full around picture. And then hopefully you guys, it's somebody that you can pull up a past EKG too and compare.
Yeah, if the EKG looks abnormal, if we're seeing SC segment depressions or there's T-wave changes, those are actually, for me, if I'm seeing T-wave, if I'm seeing progression on your EKG, I'm more likely, and part of our algorithm we use to determine low risk, medium, high risk, stay in the hospital, go home, outpatient follow-up.
You mean there's more than just one EKG?
As it turns out, and again, another theme of the show is you need multiple points of data to be able to determine a trend. So if you, or let's say you go normal science and now you're left bundle branch block. In the context of I don't feel right and having chest pain, I'm going to admit you all day long because you've now had a change. I don't know what that change is from. I need to verify it's not a cardiac chest pain. But just because you're having chest pain doesn't mean it's your heart and doesn't mean your musculoskeletal system. It could be lung pain. It could be a pulmonary embolism.
Esophagus.
You could have popped a bleb.
Yeah.
And now you have...
Could be varicella. I've seen hospital systems where I remember the fellow at one of the hospitals was working a guy up for chest pain, and the doc walked in and lifted a shirt up and saw a rash, and he was like, this is where your pain's coming from. It's like, oh, you should expose that, I guess. Yeah. But life lesson for me.
I mean, that goes down to a full and detailed assessment on all your patients, right? Now, this wasn't part of the question, but I want to extrapolate this out because this seems to me like it's the next logical discussion point is, all right, I as a pre-hospital provider think it's cardiac in nature. Everything lines up. It scans. I'm treating it as I give them a nitro and the pain goes away. Is that a slam dunk that this was cardiac chest pain? And I think, there's been the thought that that's the only thing that it's going to affect, and it's clearly not, right? It's a tongue
dilator, so.
Yeah. Well, if it's going to work on smooth muscle, it's going to work on all smooth muscle. That includes vascular smooth muscle, which is our target.
Sure.
All right, but turns out
also works in the lower esophagus.
Also, from what just neck down basically is all smooth muscle, and what about our lungs, right? There's
pain on inspiration, chest pain on inspiration, those types of things.
But all of the that's not an absolute slam dunk if
it's relieved,
a nitrate gives relief. So
well, and I think too, like Caleb's point, Dr. Hill's point, no matter what the cause is, if you're having pain here to here, you should definitely do an EKG. Yeah. Obviously, right? Some people, you don't want to get in the mindset of, well, I don't need to do it. It's not like it's an invasive skill.
The story doesn't match up.
Yeah, just do it.
Just do it.
Just do it. You know what I mean?
The old nose to navel.
Yes, I'm a big proponent of that, and then that's something you can. Then something you do not miss. It's something you rule out. It's just I don't know. It's something you should do.
I think the other thing that we don't. So I've known providers that fallen into the palpation trap, right? They have pain on palpation. It can't be. Well, no, it can be. The flip side to that is, I feel like EMS as a whole, we've hyper focus on musculoskeletal or cardiac to the exclusion of vascular injury, and for some reason I think a lot of times that kind of gets brushed aside as history of aneurysm or any other type of vascular disease or anything going on with the familial history of such. For whatever reason, I'd like some input from you guys, but I feel like we don't ask those questions a lot of the time. I mean, I forget sometimes too, right?
I feel like it's more of a direct question. If somebody gives you a pinpoint response, it's going to change your mind. But I agree with you that I think maybe we should be looking further. There was a case not that long ago I QC'd for one of the docs, and it was just that. It ended up being a AAA, but it wasn't caught at first.
It was an atypical presentation.
It was an atypical presentation. The guy was complaining of chest pain. In the narrative, it states that he was bending down to do something, stood back up, was feeling chest pain, sat down, called the ambulance. Pressures were good, but if you looked hard enough, there was a differentiation between left and right arm. Yeah. And EKG was maybe a little ischemia showing, but maybe not. It was borderline. But again, it was they treated cardiac-wise, STEMI-wise, thinking that maybe they're missing something there. They got him to the hospital, which was one of the best things they could have done, right, quickly. And then through imaging and the rest of the story, they picked up. But talking to the squad crew, it was, well, they didn't say they had excruciating pain between the shoulder blades or it wasn't sudden onset.
Not every patient, not every disease process reads the
book.
Classic presentation. I think PE, I think, is a great example of that as we talk about what EKG changes are on pulmonary embolism. Well, that's only presented 25% of the time.
S1Q3T3 you're referring to? Yeah.
Yep. And then there's also debate in the literature about what is the presenting rhythm for pulmonary embolism. Is it tachycardia or is it a normal EKG?
Normal EKG. Yeah.
So, I mean, they could be, if you're on a beta blocker, it's probably going to be a normal EKG because you just probably can't mount that tachycardia.
You can't mount, yep.
I would say that I've always taught that the number one EKG finding for a PE is tachycardia, though, if you're going to have one.
Definitely classical teaching, but
sure,
yeah. Increased work of breathing, your heart rate's going to go up. Yeah, makes sense.
Also based upon clot burden, right? if you've got a small PE that it's causing you some pain, that you're not going to be tachycardic, you're going to be normal.
Submassive.
Nothing else,
submassive. Right?
Yeah, nothing's. Your heart's not under. You're not seeing any heart strain. Troponins are normal. You don't have RV dilatation. Everything's otherwise normal. Then you're killing off just a little small part of your lung, and that's painful. That's causing chest pain. You're not going to see the other changes, as opposed to a massive PE, or you're totally occluded one of your lungs. You're going to see heart strain. You're going to see all the other things that go along with it.
I think that the patients who are borderline complaining, like, yeah, there's a complaint there. It's driving me nuts. I took Tums 3 times now over the last 6 hours, not getting better. Those are the ones that we get complacent on, that it's like, all right, I'm going to do a quick EKG. You're fine. But those are the ones also that we need to better ourselves through, like, questioning history.
Well, I mean, is that someone you do your 12 lead on because you're concerned that this is a cardiac chest pain, they could be having ischemia, and then you take all those leads off and put them on your cot and then go? Or is it someone you leave on your monitor?
Yeah.
And
I wasn't even listening to your question, but that's the answer.
Yeah. No, but this is a great opportunity too to talk about. I always like this one, the scenario of a fireman in rehab, and they're working. It's a hot summer day. They're working rehab, so they've been working the fire and overhaul. They're now in rehab, and they get an EKG because hopefully that's what they're doing because he's not feeling good, and they're seeing depressions. Like, this guy needs to go, and if he's refusing to go, you at least need to print that and say, take that to your cardiologist like now, and show them this because
you're having signs of ischemia.
Yeah.
Right?
Ischemia is not normal.
No. It's a sign that you're not getting enough blood flow to your heart.
Yeah. That's actually, I'm glad you said that. That's actually something that I struggled with as a early provider in ACLS. Just thinking about, you see so many chest pain patients, right? And it took me a while to cement just that. Such a simple concept, right? Which means my heart's not getting enough oxygen. And with ACLS, where they're trying to get us to this very finite stable versus unstable, and they would always say, oh, the unstable patient is somebody that has, chest pain is included in that unstable, right? And you should, work towards electricity. And I was always hesitant because it's like, well, I mean, if they, walk to the cot and they just had a little bit of, discomfort, this and that, I would probably do the medicine rather than the electricity. But when you take all that away and just think about it physiologically, it's that heart is telling you it's not getting enough oxygen.
You have to look for
it. But again, it was like, it's a marginal thing. I'd have to have some other signs and symptoms before I'd pull the trigger on electricity. I wasn't aggressive enough in that thinking early on in my career.
But why are we treating infarction when we should be treating ischemia? Because infarction is not reversible. Ischemia is. So I don't know. We don't fix infarcted hearts. They're dead. Death of tissue. We fix ischemia. So it should be, ST, elevation myocardial ischemia, not infarction that we're looking for.
We are, and you should be treating it, I guess, is my answer. Now, I think what you're delineating there is the delivery of the P2Y inhibitors and heparinization of that patient. And again, you're always allowed to be smarter than the protocol and call
Pick
and
up
say,
on that,
here's what's going on. Is this an appropriate case? But, the treatment may be as simple as providing supplemental oxygen and just, doing the things until there's a complete imagery.
And without
lab diagnostic value,
digressing,
you have the whole picture.
Even a basic EMT can get that picture by sending that 12 lead to the physician who can look at it and say, oh, this is what I see.
Sure.
I think that probably in our mind what we've done is we've said, like, STEMI's bad, which is obvious, right?
True. Right.
And STEMI's so bad, we're going to turn on the big machine and get the doctor in here to fix it right now. Right. So obviously that's an emergent situation that we're to hit goals for less than 90 minutes toward a balloon, that type of deal. Other ischemia, every time you guys get called, every time someone calls 911, they believe this to be an urgent case. They want you need to be there in a timely fashion. You're not going to show up, you know what? We just made dinner.
Yeah.
How does 7 a.m. work for you? I'm going to push us off to the next shift, right?
Right.
No, they need to be emergent. They need you to be seen urgently. Right. You guys get there, and then you're deciding, is this not just urgently, do I make this an emergent thing, and then we need to wake everyone up and go do our thing, versus you're having ischemic chest pain. We are urgently fixing you, but that means coming to the hospital, you're getting your aspirin or maybe starting your own heparin if it's appropriate. We're doing all those diagnostic things and then doing your risk reduction to help heal your heart, but it's not rising to the sound all the alarms, get all hands on deck.
Yep,
Well, you need some help, but we can slowly move you there in the next few hours, not necessarily next few minutes.
And I think I do kind of agree that we may have in some areas kind of painted the picture of if it's not a STEMI, it's not important. I guess that maybe important is not.
Actually, that was going to be one of my talking points. Is like you do the EKG, you look at it, it's like, well, it's not a STEMI.
Yeah,
but there's still EKG changes.
It's still urgent. It's still it still requires appropriate attention.
Mm-hmm. So. But to this whole point, the question was about chest pain versus cardiac and not. And we've spent almost 10 minutes talking about it because it's that important. Like it should have been just a quick, but it's not.
Sure.
Yeah. So it's important. It's a good question.
What are the contraindications for using epinephrine in anaphylaxis? So
the dose, the concentration.
Those aren't contraindications. Those those are definitely precautions.
Yeah.
But this is specific to contraindications, and zooming ahead.
What did Dr. Spanner say? Your patient will die of lack of epinephrine.
Yeah, they'll die from lack of epinephrine. So the short answer here, of course, is it's not. And I think where this stems from, we've all had a patient that claimed they were allergic to epinephrine or sympathomimetics because it makes their heart race or whatever. And the reality is your body produces this naturally. How can you be allergic to? You're allergic to yourself. That doesn't scan, right?
They might be allergic to one of, let's say it's additives or preservatives inside that drug, but the risks and the benefits much outweigh the risks of them getting the epinephrine because that's going to solve the problem.
Yeah,
of the anaphylaxis.
And I'm reading and interpreting this as certainly an anaphylactic shock, even in an anaphylactic reaction. If there's airway involvement, even if it hasn't, if they're not shocked yet, again, we're progressing. But we're still on that. The benefits far outweigh the risks of any allergy to said preservatives or whatnot. So,
and if it's just a reaction and not quite anaphylaxis, if it's singular system as opposed to multi-system, maybe you don't need the epi right away. But would it really hurt? I don't think there's any contraindications to it. But if you have somebody who's, like you said, might be on the fence about it, maybe just start with the Benadryl if that is okay.
I think that there's a lot of value. We can talk about this, and probably not their whole point, but teasing out when do you give epinephrine versus do you just give them Benadryl, and do you do Benadryl plus steroids, and then when do you add on the epi?
We could work from simple to complex.
I think that's funny that you said that because I automatically in my head couple Benadryl and a steroid, or diphenhydramine and a steroid, and I'm glad you separated that out because I probably would have gone through this whole discussion just coupling those in my head without
actually saying that.
Without saying that. So I'm glad you.
Well, now the new data is not even Benadryl. They're actually leaning more towards the H2s and more towards like Zyrtec than going away from the from Benadryl because of the side effects of just drowsiness.
Drowsiness, yeah.
So,
well, those first generation H1s, right? I know it was common practice years ago, and I haven't paid much attention lately. If we give the H1 blocker, the histamine 1 blocker in the field, are you guys still following up with H2s and the H2 blockers or is it kind of a provider gestalt kind of?
Probably it's more of a gestalt
feel and presentation thing.
Yeah, or if nursing wants to do it, and I say I just kind of
just okay, whatever. Certainly not going to hurt.
Yeah, definitely the histamine H1 blockers are definitely go-to. If they're kind of again, if they're really sick, they're going to get everything, right? They're going to get a Benadryl. For us functionally, they're getting IV Benadryl. They're getting IV Pepsid. They're getting their Solumedrol, and they're getting IM epinephrine. Yeah. And nowadays, I'm leaning even more towards the higher dose IM epi. If I'm concerned that much, I'm going to give you the higher dose. I'm giving you 0.5.
0.5.
Yep. Not just the 0.3.
come out swinging. And
yeah, exactly.
Why not? Yeah. No, I was going to say I think
If
a lot
it saves
of
me an intubation.
Yeah.
Oh,
It's
well,
absolutely
yeah.
worth it.
Saves them an intubation.
some providers I don't think couple the albuterol in a solumedrol or the steroid because they don't see immediate action with the steroid. But you got to remember it's more of a long-term thing, and you're really doing a lot of good justice with giving it. I think Dr. Yaski even talked about that in pediatrics anaphylaxis, that giving it, they're seeing way better outcomes in the EDs than what we do, but we don't see immediate action with that. And I think sometimes it's like, we get to it.
We did a whole segment on steroids
It's
alone.
Yeah, we just don't see the immediate return, but I think the emergency room sees the immediate return, and then you look at any type of re-entry decrease statistics with decreasing the re-entry of shortness of breath, and the longevity of solumedrol being given early in the field is huge, and in the pediatric world is very beneficial. Hours down the road, we do not see that return. So for us, we're used to anaphylactic reaction, multiple systems being affected, so that's what triggers our epi versus a singular system. We give the epi, we see a pretty fast return. You give Benadryl, you see a pretty fast return. But solumedrol is really planning for the next steps for that.
And I think it's
patient's
equally
future.
as important. I think that,
that
you would get it on board if it's.
Yeah, even and I think it's good to bring it up too, even if it's like, say it was a pediatric allergic reaction, 1 per kilo, and that's very important.
What is the best way to manage a patient with a suspected airway burn?
LSD, like Siren Diesel.
You're fired.
I disagree. Plastic intubation.
Plastic, yeah. So,
but make your first intubation work.
Yeah.
And that's something that we talk about when we're talking about airway management, that there are certain times when it's appropriate to have your most junior paramedic go for that intubation, right?
Yeah.
The patient that has a neck, they've got a mobile neck, they don't have weird anatomy, they look like to be a low risk, easier intubation based upon whatever lemons or whatever fingers you want to jam in their throat or whatever.
We'll just go Mama Patty.
That too. Versus a crashing airway. Your crashing airway, you don't have your junior person, you have your most experienced intubator take that airway, because as soon as you even slide whatever laryngoscopy blade in or whatever device you're using, you're going to start touching tissue, and the tissue is going to start to swell, and it's going to start to become very edematous, and you're having a very limited amount of time inside that airway before things go from bad to very bad.
Would this be so rhetorical question? Would this be somebody you would throw an eye gel in?
No.
Okay.
Well, you can't.
Why is that?
So as soon as I need a definitive airway.
Yeah.
I need to be able to make sure that I can ventilate the patient into their lungs. The only way that I can guarantee that is an ET tube from the outside world, either intranasally or through the oropharynx, all the way in through and past the vocal
glottic
cords.
opening. Yeah.
Eye gel doesn't give me that.
Would this be somebody you could put on maybe humidified oxygen while you're prepping that?
You could.
I don't know if
how many humidifiers do you have in your?
I'm just throwing that out there. Or what if you threw some saline into a nebulizer, put it on their face, and then you prep your stuff? Is it worth it? Is it worth the extra step? And it'll only take an extra 30 seconds to, a cooler mist. Is that worth it? Not worth it.
My gut says that that 30 seconds should be executed elsewhere, not on setting that up.
Maybe I'm pre-oxygenating my patient in preparation for your intubation, but that's about it.
Okay.
The extra 10 seconds, 30 seconds of getting your nebulizer
ready for the
intubation.
Sure.
See,
I'd much rather just have pre-oxygenated and...
Okay.
Yeah, but, we're going to be flow limited to 6-8 liters.
Sure.
If you're using a nebulizer, my brain says I want 15-plus liters coming out of that rebreather if that's the tool I'm putting on for pre-oxygenation.
Yeah, obviously case dependent.
Oh, 100%.
Sure.
I think that's what we have to kind of talk about here, because if, he's a plastic, that's assuming we got this patient early. They haven't started swelling up.
Correct.
They're not all charred. Their face isn't all charred and all full of soot or, whatever other garbage that we can actually get in to the mouth.
Yeah.
Right?
Yeah.
So there's a lot of assumptions here to answer this question. It's if you can get in top down,
that's great.
you have to, but
do we need to
you
go
have
down?
to do that best intubator and soon.
With your next best intubator prepping the neck.
Neck.
Just in case.
Yes,
Correct.
just in case you have
And you have to have a very,
Yeah.
very short threshold, in my opinion, or a very, very short trigger on anterior access in the neck if that's not going to work.
Yeah.
And if you're a basic med unit, this is a good time for LSD, light sirens and diesel, and maybe ALS intercept because your patient may crash on the way. Make sure you're calling the ER early so that they can get respiratory anesthesia there because you're going to want troops in the house.
Sure.
Well, let's back it up a little bit too. Let's say, I mean, I think we took, and it's hard sometimes with these questions, we take a couple things for granted. That, okay, the patient is just magically cooperative, and I get that chance to just be like, okay, I'm going to intubate you and protect the airway. Now let's take a hysterical patient that cannot breathe. What other steps can we talk about?
They're stridorous.
They're stridorous. What else are we going to need to do? Are we going to need to dose them with ketamine to get to that point to be able to then
if you're an RSI department, this might be your
or an RSI department
utilize something like that.
So the other steps to think about versus like they're magically unresponsive and I just get to go right to intubation. Yeah, to like everybody's point, and I know the question isn't elaborate, but yeah, those are things you're going to have to think about. If I'm not an RSI department, then I'm going to start with ketamine, and I have Versed as well. Then if I'm an RSI department, then I have ROC, I have ketamine. Yeah. Obviously, intubation is our prime thing that we want to do, but what happens when you get in there and it's swollen? Like, it closed, you can't get to it, then you got to flip, and now you have to crike. Like, crike is our absolute last resort. Obviously, that means nothing else will absolutely work, and then we get to that point.
But it should be early in your critical thinking when you're about to RSI.
Oh, yes,
yes. Early on, you should have that kit out, open, ready, even if you don't use it.
You need to be
the hospital replaced that Rouge. So, but you said something that really strikes me is that the oxygen reserves. That's crucial on these patients because if you get there and this is a chronic smoker who lit their nasal cannula up and it's melted to their face still, they're probably crap for reserves to begin with. You're really going to want to pre-oxygenate them as best as you can while you're getting everything set up.
Let's say this was a fire. Then they've sucked in all kinds of byproducts of combustion on top of that, right? You're really working against a bunch of things. But the two things, it's when I read that question, it was immediately, there's two answers, and they come out at the same time in my mind, is a knife and a tube, right?
Yep.
Which of those I use in which order really depends on the presentation, or if I can get a top-down view. If I can't get a top-down view, then I transition quickly to the knife.
And it takes a lot of experience to identify which one you're going to go to.
Yep.
Or even jump to, do they need an airway, right? So, I mean, I was in a fire, I got myself out, hey, man, I'm coughing up some stuff, but I feel okay.
Singed hair.
Well, maybe they don't even have that. Maybe you look at them and you don't see any carbaceous material on their face.
Or anything,
their sputum is not black. They don't have any singed facial hair. You have them open up. Looks like a normal oral pharynx. Don't need intubated. They need monitored. Oxygen, capnography. If you can do carbon monoxide, we can then worry about cyanide poisoning depending upon what was in the fire, but should go to the hospital, doesn't need intubated. Versus singed facial hairs, carbaceous material inside the oral pharynx. How far back does that go? Is it just at the teeth?
Yeah.
Is it in the posterior oral pharynx? Do I see swelling back there? How interactive are they? Are they a true fire victim and they're unconscious and they just need intubated? Versus are they walking, talking, coughing a bunch of things, coughing a black sputum? They've got the carbaceous material all in the back of their mouth, and they're like, if it feels tight or feels weird and different, those are the patients that you just need to jump to.
Really need to watch.
Yeah.
And
here's the oxygen.
That was the case I was going to throw at you. We had several, but one that sticks out to me a few years ago was a kid that came out of a house fire, and he had singed hair all over, and he was still not. He needed to be watched like a hawk, but at the same time, we didn't have to intubate him. He was fine. He was breathing. He was maintaining his own airway. I think that having put anything near his mouth would have probably swelled him up, and that would have been the end. But we were close enough to the hospital. We just elected just to take him. He was fine. He was communicating with us. He wasn't coughing, but he had obvious burns.
And that's probably the best thing that I do with any of my patients that have airway involvement, whether that's from angioedema, whether it's from anaphylaxis, if it's any type of trauma, which is going to be burns as well, is that constant reassessment of them and talking to them like, I need to know if things are getting worse, better, or they're staying the same. And the sooner you tell me that things are getting worse, the better options I have, right? I don't and I've told this before, but like when I had to do my first crike, I went in there to find this guy.
Right,
open his mouth, his
Yeah.
saliva falls out of his mouth. I'm like,
You got backed into a corner.
I did.
Yeah.
I could have fixed this minutes ago.
Yeah.
If you would have told me on the other 5 times I checked on you that it's getting worse, great. Way more controlled environment. I could go in there. I could probably see everything I need to do. We can intubate you from up top. You go to sleep nice, and everyone has still a butt pucker moment. A way more calm and controlled event than what actually ended up happening to this poor gentleman who ended up getting a cricothyrotomy.
And have you guys ever criked?
No, never on.
I've come close. I've never done it.
So
So it's like I don't know. We've obviously trained on it. Pig anatomy, cadavers, but I don't know.
Our crews did once, and then we nearly needed to use that as a backup option recently as well. But myself personally, just cadavers.
Yeah, that was my case that I've shared with this group. Is we threw, at the time it was just nebulized epinephrine at the patient, and bought that patient time to get to the hospital, and then they went to the OR and got a tracheostomy.
That was this pre you having video guided laryngoscope in the squad? That's relatively new.
So that predates 2 things. It predated VL, and it also predated racemic epi on the truck.
Okay.
And we didn't even have protocol. For nebulized epinephrine for Strider at the time. I actually called and got an online medical control order for that. I'm like, hey, this is playing like this. I know racemic would be your choice in the hospital. I don't have it. How do you feel about nebulized epi?
Yeah.
And
they quickly said
just a lot more of it.
And I honestly, I remember that conversation much like it was yesterday, and it was 20 years ago. And he's like, yes, absolutely do it. And got a little bit better. She was BiPAP'd in the ED, and then subsequently, like I said, went to the. While I was still there, so I mean they were moving very quick. So I mean within 20 minutes.
Depending on that time frame, we say we don't have at that time we probably didn't have all the tools we have now in the emergency department.
100%.
Like now, I have fiber optics that I have available to me in the emergency department. The fiber optics aren't quite as nice as what they have in the OR. They have a lot more tools in the OR, but I still have a large breadth of things that I have in the ER that I can do to help facilitate that intubation. And we talked about during our airway series too. Go watch that. That's very good content. But when you're doing an airway, you need to prepare to fail.
Yeah.
You're going to have, this is my first method. This is what I'm going to fail to. I'm going to fail to this. I'm going to fail to this. And ultimately that's going to lead down to cricothyrotomy. But it shouldn't be, although for most intubations, burns might be different, or you're going to fail directly to that crike. But it should never just be, I'm going to look up top and then my second step's a crike. It should be, I'm going to look up top, but by looking up top, if I can't do, if I'm looking with
1A, 1B, 1C, 1,
it's going to be some combination of video direct, bougie, iGel or supraglottic airway,
ramping the patient. I mean,
repositioning, cric pressure, and then it's always going to be cricothyrotomy at the end. But you might look in and go, yeah, well, I'm on 1, and I've skipped 2 through 8, and now 9 is cric.
Yeah. Have you had a lot of luck with the backwards, upwards, rightward positioning?
Sometimes, yeah. I might get in there and I don't have a great view, and I ask for cric pressure a lot in those circumstances, and it might move it down just enough that I can easily thread it.
I feel like ever since AirTrack and Palmidine products, I feel like it's so much easier now. It
is easier, but even so, you guys use AirTrack in the pre-hospital space. A lot of us in the hospital space use glidescopes.
Yeah,
it's our go-to. But even with those hyperangulated blades on a glidescope or any other of the products, you still may not be able to get up to that recess. And if I can't necessarily do that and pressure doesn't help, then I have a bougie always as my additional aid to get up to the space that I need to get up into.